Hi everyone. This is the first ever Get Reporting with me. We're going to be going through gynecologic ultrasound cases to show you real life gynecologic pathology. And this is what it feels like to be in my shoes or in my office chair, where I am reviewing the images and cine clips recorded by my sonographers and doing my reports. This case is a 39-year-old female who presents with a history of abnormal bleeding. And what we do know about her from her history is that she has had several cesarean sections. The bleeding has gotten worse in recent years, and it now includes 2 bleeding events every month. On the screen, we have the first image captured by my sonographer, the first transvaginal ultrasound image. And as you can see, we're measuring the uterus, which measures 112 millimeters in its length. Its height measures 45, the anterior-posterior measurement. And before we have our width measurement, my sonographer is giving me a right-to-left cine loop of the uterus to be able to capture many things that cannot be captured in a single image. When cine loops are recorded, I usually will pause the cine loop at some point, and I will slowly scroll back and forth through the uterus or through whatever structure we're looking at to be able to appreciate features. So as I'm scrolling through, I'll pause and I'll hover over a few interesting things. In the posterior myometrium, at the level of the junctional zone, we have a very clear irregularity here. This already looks like a feature of adenomyosis. And anteriorly, almost directly in front of that, is another area of suspicion so far, but we're going to try to use true MUSA criteria to be able to characterize what we're seeing. So pausing just about there. We have a small myometrial cyst, a little anechoic area surrounded by a very sharply demarcated hyperechoic rim. We'll come back to some of those adenomyosis features. The other thing that's catching my eye is the activity in the lower uterine segment here at the level of where the cesarean sections would have happened. And so we do know from the history that multiple cesarean sections have taken place. And you can appreciate that actually there are probably multiple levels of incisions that have happened here. So the hysterotomy site has been different at the various cesarean sections. Don't get too distracted by these circumferential circular anechoic areas here. These are Nabothian cysts within the cervix. This is the area that we want to focus on. And in particular, we see here there's a small anechoic cystic area within one of the scars, which should raise some concern for a cesarean section isthmocele. That area here also looks to me like it's part of that process. And when we're evaluating that, we sometimes can actually try to appreciate whether there is continuity between little cystic areas. And so it's not super obvious on this cine clip, but we may see something a little bit later. All right, so here we have our width, 63 millimeters, which gives us an overall volume of the uterus of 167. Taking some standard views of the ovaries. So we have a right ovary measuring 18 by 27 by 20 millimeters roughly, with a volume of 5.1 milliliters. And so this is a pretty standard size ovary. We can see some follicles present. Coming to the left side, we see a clear difference. On this side, we have a larger follicle. We have an anechoic cystic area. This is not an abnormal cystic area. This is a physiologic or functional cystic area. And because the presence of that follicle development, our ovary is bigger. This one measures 32 by 25 by 35 with a volume of about 12.4 milliliters. Though in most cases, it's not really necessary. We can actually measure the follicle. In this case, because the follicle is taking up the follicle is measured, and the measurement is 15 millimeters, which is pretty typical for a dominant follicle. When it's a pretty obvious dominant follicle, it's not really a huge priority to measure them unless follicle tracking is important for the patient. Here we have a cine clip through the left ovary. So like usual, I'll pause the cine clip and I'll scroll back and forth through it slowly to try and identify any abnormalities that may not be captured in a single still image. And in the context of ovarian cystic lesions, we want to be able to ensure that we've seen the entirety of the cystic lesion, all the walls, all the internal walls, to make sure that there are no solid components or papillary projections. Again, not worried here as this is a follicle, but in any case, it's good to be systematic and scroll through it. Here we have the color Doppler box region of interest overlying the ovary. And even though I already know that this is very likely physiologic, we can sometimes demonstrate a peripheral ring of vascularity, particularly after the event of ovulation when a corpus luteum forms. Just another cine clip through the left adnexa, looking for any other adnexal cystic lesions or masses. Nothing is jumping out at us. We're seeing some of the vessels going into the uterus here. We're catching the iliac vessel towards the end of that clip. So nothing dramatic here. So coming back to the right ovary, in some cases, the sonographers can see things better at different points of the scan, which may be secondary to bowel gas, patient comfort. So in this case, we have a remeasure of the right ovary. It's not particularly different than the previous measure, and the view is already pretty decent. So this may be a little bit more crisp circumferentially, but doesn't show us any more new information. Similarly, customarily, we add the color Doppler box over these structures to appreciate any abnormal blood flow. And in this case, we don't see any evidence of flow within the ovary. However, there is nice flow surrounding the ovary. And as usual, here's a cine clip. And so as we're scanning through, we'll pause. We see a normal number of follicles, roughly 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and maybe 13, but this is below the limit of 20, which is the most evidence-based threshold for diagnosing polycystic ovarian morphology. We'll hopefully get to see those types of ovaries in another case. Here we have the loop through the right adnexa, really not showing us anything of great interest, no abnormalities identified. So now my sonographer has come back to the uterus because there were some original flags identified. And as you can see, the region of interest here is hovering over this anechoic space at the junctional zone posteriorly. And rightfully so, my sonographer has applied the color box to try and elicit blood flow within this space, as there is a bit of a length to it, in which case it could represent a blood vessel, but this would be an unusual region of the myometrium to see a blood vessel. So I'm more convinced that this is actually a cystic space due to adenomyosis rather than any normal physiologic process. Nothing particularly dramatic in that region of interest. And so now we're scanning through the uterus again, with a little bit more focus on the fundus. So let's focus in this region here. And as I've just paused, completely accidentally actually, we have a very nice echogenic line. This is the subendometrial echogenic line, which is a direct feature of adenomyosis according to the morphologic uterine sonographic assessment group. And in that same region, we do see some other very subtle echogenic lines. We come down a little bit lower here. We have to be a bit careful as we enter into the lower segment region where there is a history of cesarean section, but we can definitely appreciate some irregularities within this area of the junctional zone, which we would call an interrupt junctional zone due to the changes in the overall thickness of the junctional zone here, much more than down here. And then right there, we have another area of a myometrial cyst, very similar in appearance to the one we saw posteriorly, anechoic contents and hyperechoic rim. So I'm pretty convinced that this patient has evidence of adenomyosis via several direct features of the Musa Group's consensus statement. But just to point out, the overall uterus is not globular. There's no asymmetry between the anterior and posterior myometria. There is actually not really much in the way of dramatic fan-shaped shadowing from the adenomyosis regions itself. There is a little bit here. We're actually seeing acoustic enhancement behind this myometrial cyst, and then just adjacent to it, a bit of edge shadow. But a lot of the shadowing is actually coming from the lower segment. And so we have to be careful when we're talking about shadowing that comes from the periphery, that comes from fibroids, that comes from scar, versus fan-shaped shadowing that comes from adenomyosis. Running a cine loop through this with color Doppler on, and overall very normal blood flow patterns. Here's a transverse sweep. So if we scroll through that, we can actually appreciate a few myometrial cysts here. There's a really nice depiction in transverse of an echogenic line, capturing more myometrial cyst activity here. So we're getting more and more confident in our diagnosis of adenomyosis in this video. And then just a bit more focus on that lower segment to be able to try and appreciate if there are any Cesarean section niches or isthmoseals. Those are the same thing, different names for the same thing. So as you can see here, my sonographer has put calipers on the cystic space within that lower segment, which represents a little bit of a cystic area within that lower segment. Overall, I would not characterize this truly as an isthmoseal. This is more a small cystic space within a scar. An isthmoseal would be more in continuity with the endometrial cavity, resulting in blood being entrapped in that space, fluid being entrapped in that space over the course of a menstrual cycle. And we have a normal thickness endometrium with a nice midline linear echo there. So I think we're coming to an end in terms of the assessment of this uterus. So we clearly have a case of adenomyosis and several Cesarean scars. Check this out. At the end of this clip, we're starting to appreciate actually that this most superior, close to the fundus, Cesarean scar does actually have a bit of a tent shape. And so this might be a bit more representative of a true isthmoseal. So this here, if I were to put my calipers on this, I would measure it from here to roughly here, just around that line that you would connect the lower segment endometrial canal to the anterior surface of the endometrium here. Roughly, though it's not a precise science, there to there. So we have an isthmoseal measuring 5.8 by 7.6 millimeters. Now we can try and go back to the previous transverse and try and appreciate the transverse width of the isthmoseal. But while we're here, we'll measure one more thing that is of great relevance, which is the residual myometrial thickness going from roughly here to the top of that isthmoseal. So about 4.7 millimeters. There's also an importance from a surgical planning standpoint to measure the adjacent myometrial thickness, which is approximately 8.9, 9.0 if we round up. Well, let's just quickly go back. Let's see if we can pause on this one. So maybe, just maybe, what I originally thought was an echogenic line can actually be part of that isthmoseal process. So this is that transverse aspect right there, 5.7. So it's really important in real time to be going back and forth and trying to connect the dots when you're trying to complete your report, as you may catch something later in the scan that you need to come back to earlier on. And this is where cine loops are really essential. Without these cine loops, if this particular image was not captured by the sonographer, and in the case of more complex issues like cesarean section isthmoseals, it's not quite present in guidelines or regular standard of care imaging to be able to capture those subtle things at this point. With time, yes, but for now, cine loops can be the avenue to capture those details. So we have a potential pathology here that can also yield abnormal bleeding patterns. So if we come back to here and we pause on that cine again, so there we have that measurement of the RMT and the AMT. I want to just point out that a sonohysterography may be able to more elaborately evaluate the size of this, as currently there's a collapsed state of an isthmoseel, and there is clear content of endometrium within that. When a sonohysterography is completed in SIS, this space is filled with fluid, allowing you to get a more true sense of the capacity of the space. And that can give you some more characteristic of the extent of the isthmoseel, which may provide a bit more refinement in the surgical planning, if surgery is going to be considered for that. But in this case, depending on pregnancy desires, if this uterus has adenomyosis, that's probably driving more of the bleeding abnormalities than the isthmoseel itself, and that may be more of the focus of treatment rather than the isthmoseel. However, if this patient is going to keep the uterus and would like to use it, this isthmoseel could impart some issues down the line that we should pay attention to. And just at the conclusion of the scan, my sonographer has taken a few transabdominal pictures just to ensure that there's nothing we're missing that's large off the surface of the uterus, a fundal fibroid, for example, a large ovarian or adnexal mass, and there's nothing present here. So this was our first Get Reporting with Matthew. I hope you have enjoyed this and found it educational, and enjoy the series of videos that is to come. Thank you.